And here we are at the scientific sessions of the American Heart Association. But where we are geographically, we are nowhere or everywhere. This is a virtual transmission. And I hope that with the excellent today collaborators of mine, we can really go over a number of studies that have been presented in the meeting, which are actually some of them quite interesting. Just to give you a sense, we have 4 studies related to pharmacology, all very interesting, 4 about coronary artery disease, there are 2 about heart failure, and 3 about atrial fibrillation. So I hope we don't get an indigestion here, and we will try to be as succinct as possible. But let me now introduce my colleagues, outstanding, all of them. Here we have Dr. Christine Albert. Say hello.
Hello, everyone.
Chair of the Department of Cardiology at the Smith Heart Institute at Cedars-Sinai in Los Angeles. Dr. Athena Poppas.
Hello, Valentin.
Thank you. President of the American College of Cardiology, Chief of Cardiology and Director of the Lifespan Cardiovascular Institute at Rhode Island. And then we have from Paris, we want to be very international tonight, Dr. Gilles Montalescot, Professor of Cardiology and Director of the Cardiac Care Unit at the Pitié-Salpêtrière Hospital, again in Paris. And then why not? We always need a surgeon. And we have a very good one today. Dr. Vinod Thourani, the Marcus and Chief of Cardiovascular Surgery for Piedmont Healthcare at the Marcus Heart Valve Center at the Piedmont Health in Atlanta, Georgia.
Thank you, Bill.
Well, thank you very much. Well, here we are and ready to go. Let's begin by addressing, if we can, the 4 pharmacological papers. And let me start with the polypill, the TIPS-3 study in 2 different publications, but I will summarize. This study was presented by Dr. Salim Yusuf from Hamilton, Ontario, and is entitled Polypill with or without aspirin in persons without cardiovascular disease. Let me introduce the subject. There's one thing that is clear in the polypill is to take a polypill is easier to take all the pills separately, and there is enough information in the literature that adherence improves. The question that is debatable, are we going to give a polypill for primary prevention without knowing the background of the individual? Or are we going to give a pill to secondary prevention that we know the guidelines, what the specific drugs to be given? Well, let's get out of the debate here because this is just for primary prevention. These are a 2x2x2 factorial design with the following 3 strategies. The first one was the polypill in itself containing simvastatin 40 milligrams, atenolol 100, hydrochlorothiazide 25 milligrams, and ramipil 10 milligrams. So 3 blood pressure medications here. Then we have a combination of such polypill with aspirin. Okay, and this is the third one is just aspirin alone. And the question is how these polypills do on a number of issues that we are going to talk about. First, how cholesterol is modified or blood pressure is modified by these 3 approaches. And the second are the endpoints. And the endpoints actually are basically myocardial infarction and stroke as important ones. But in addition, in the polypill alone or combined with aspirin, we have in addition cardiac arrest, heart failure, or revascularization and actually death. Well, with this in mind, let's see what happened here. Over 5,000 participants underwent randomization in the 3 different arms, as I mentioned, and the follow-up was 4.6 years. What happened with LDL cholesterol? Overall, there was a decrease of 19 milligrams per deciliter in the pill that contained statin. What about blood pressure? Also in the poly pill, with the 3 blood pressure medications, the systolic blood pressure dropped by 5.8 millimeters. Well, what about the results in terms of the heart endpoints? Well, a poly pill in itself, without aspirin, had the number of events were 4.4% versus the placebo 5.5%, again at the 4.6 years of follow-up. Then, if we add aspirin, we have 4.1% in the combined group, polypill plus aspirin, and 5.8% on the placebo. And finally, aspirin alone, 4.1% versus 4.7% in the placebo. The incidence of hypotension or dizziness was higher in the groups that received the polypill than in their respective placebo groups, as one can understand by the 3 blood pressure medications. In conclusion, as it is pointed out in this in the New England Journal of Medicine just published, combined treatment with a polypill plus aspirin led to a lower incidence of cardiovascular events that did placebo among participants without cardiovascular disease who were, they say, at an intermediate cardiovascular risk. Well, impressive, not impressive? Athena, what do you think?
Not surprising, but and so not terribly impressive, I would say. And I guess the issue about aspirin comes back again to haunt us. So that, for me, was something. I think the third thing was not a great drop in blood pressure, considering we used 3 different agents. So makes me reconsider aspirin.
Thank you, Christine.
Yeah, I had the same take. We had just sort of put aspirin to bed, and now we have another trial on primary prevention who suggests that it's beneficial. Maybe when combined with other agents, I don't know, but does muddy the water a bit.
Okay, thank you. Gilles, you like this business of polypills. What do you think?
I think it's attractive to have everything in one pill. I'm surprised by the fact that they used the maximal doses of all these drugs, and it was globally, if I understand well the paper, it was well tolerated, and few patients actually discontinued the treatment. I'm surprised by this, and I think that at least in my country, many patients would probably stop the treatment, whatever the reason, but for a mild effect, if they get this kind of polypill. So for the efficacy endpoint, I don't think it's very impressive. A 1% absolute difference on a combined endpoint at 5 years, it's a tiny difference.
Thank you very much. Vinod, you appear to be quite healthy. Would you take this polypill?
Right now, I probably wouldn't take it because the benefit doesn't seem to be tremendous. The only thing that I think I do like about it is that as patients have more and more medications to take, combining them makes sense to me. But I think you'd have to figure out the dosages a little bit before you'd go straight to this.
There were a few issues, actually. The adherence was poor, and this was one issue. So the feasibility is always a problem in primary prevention because you give blood pressure pills to people who may have normal blood pressure and so forth. I think it's a good exercise. I think it's published and it's okay. You know, we have a secondary prevention polypill study with 5 countries, which will know the results in the next year or 2. But there we know these are patients following myocardial infarction. So we are giving the drugs that we are supposed to give. And we'll see what happens. But anyway, yeah, I think it's a good exercise. But frankly, I don't see how feasible this can be in the future. Well, good. We are doing very well. we are very well because it just took 5 minutes in the first paper, but we have 13. So if you multiply, we will not go to bed tonight. But look, this is the polypill. And now let's go into the second paper. This is an interesting one. It's the one ivanukumab in patients with refractory hypercholesterolemia. This paper, the first author is Dr. Robert Rosenson here from Mount Sinai. And basically, there are a few interesting things to mention here. First of all, that in the United States, about 7% of the adults have a very high LDL cholesterol, more than 190. In about 10% of these people, this is familiar. But what is very interesting is that these people who have high LDL cholesterol, in particular the familiar ones, they tend to be resistant to everything, or at least you don't reach the levels of 50 milligrams DL with treatment, with PGL9 or with any of the statins and so forth, or 70 milligrams DL. You don't reach those levels. So to look for new medications is a possibility. And this is a very interesting study in this regard. Very basically, this angiopoietin-like 3 is a molecule that tends to keep the cholesterol in the blood rather than getting the cholesterol into the cells of the liver. And therefore, what about if you inhibit this molecule? And this has actually been achieved by drugs of this type. Evinacumab is one of them. And there is some preliminary data that this could be successful in the most resistant patients who have hypercholesterolemia. Let's now go into the paper. So this was a double-blind placebo-controlled phase 2 trial involving patients with or without familial hypercholesterolemia, but who had refractory hypercholesterolemia with a screening LDL cholesterol level of 70 milligrams DL or higher with atherosclerosis, or 100 milligrams DL or higher without atherosclerosis. These are the patients who entered into the study. The goal was not achieved with the other modalities of treatment. So these patients received subcutaneous or intravenous evinacumab or placebo. And the primary endpoint was the percent change from the baseline in the LDL cholesterol level at week 16 with evinacumab as compared with placebo. I think this is important that this medication is given either subcutaneously or intravenously. If I recall, they used 3 different dosages of subcutaneous. I don't have to go into the details. And then one dose, these dosages was weekly. Actually, I can say 400 milligrams of the drug and 300 milligrams weekly. And then they gave another group 300 milligrams every 2 weeks. And intravenously, 15 milligrams per kilogram every 4 weeks versus 5 milligrams per kilogram every 4 weeks. Well, let's go into the bottom line of the results. These drugs really work. Remember that when the drug is given, the others that have been given are still there. So the statins, the PCYs are all there. So you are adding this drug, and in the placebo are all the drugs that have been given. Well, the results were interesting because in the appropriate dose was a 50 to 56 milligrams DL decrease in the LDL cholesterol levels, either subcutaneously or intravenously. I don't have to go into the details of the dose, but certainly the conclusions of the paper also published in the New England Journal is in patients with refractory hypercholesterolemia, the use of evinacumab significantly reduced the LDL cholesterol level by more than 50% at the maximum dose. I think the results are quite interesting, and I'd like to, let me call the surgeon first. Are you impressed by 50% of these kind of figures?
No, I absolutely I am. I mean, I think that, I think that becomes important. I mean, we see a lot of this after we do coronary bypass surgery on patients, and this has to be managed more aggressively, especially in patients who have proven to have significant hypercholesterolemia that's refractory. And a lot of those people end up in our operating room table. So I think something like this becomes important for us for long-time management. I'd like to know how they work on coronary bypass patients and vein grafts down the road. So I think this is an important topic of discussion.
Christine?
I'm very impressed, and I really liked how they did the different dosages, and kind of really worked out what the ideal dosage was, and that you could give this subcutaneously, and it would work, relatively infrequently. Every 2 weeks, I believe, is what the subcutaneous was. So I think this is a great advance forward for hypercholesterolemia management.
And we're not just saying this is because it's from Mount Sinai, Dr. Fuster. I just want you to know that.
Yeah.
Thank you very much. Okay, thanks. Athena?
Yes, again, equally impressed. It's a dramatic drop in LDL cholesterol. The caveat is patients, we just talked about a polypill. It's hard to get patients to take a lot of medications, pill or injection. So do we add this to existing medications? Is there a high enough dose that we could give this and exclude the other medications? Those are some of the questions that would be nice to answer in the future to simplify it for our patients.
Thank you. Thank you. Gilles?
Yeah, the decrease in LDL is very impressive in these patients. All of them had PCSK9 inhibitors on board. So this is in addition to what we have, which is the most potent treatment, actually. And there's something weird about this drug, which is also the decrease in HDL cholesterol. I don't know what the impact is going to be of this decrease of HDL. And I was surprised by the number of side effects of these drugs, urinary tract infections, anaphylaxis, abdominal pain, dyspnea. We need to know more about the tolerance of this drug.
Yeah, I was going to comment on this. In the subcutaneous, 11% had urinary tract infection, arthralgias in 5%, myalgias in 5%, and in the intravenous, some dizziness or fatigue or abdominal pain. So maybe they have to work more on the dosage of these drugs and so forth. But certainly, it's quite positive results, and actually the number of patients who discontinue the medication is relatively few, despite of what I mentioned. Well, it is a very interesting one, and let's move. Now going to the next paper is another pharmacological paper. It's the so-called GALACTIC-HF study presented by Dr. Teerlink in San Francisco, and is entitled Cardiac Myosin Activation with omecamtiv mecarbil in Systolic Heart Failure. Well, this is interesting. I never heard of this mechanism, but basically this is like mechanically or chemically, this drug actually gets hooked into the myosin activator and makes the myosin to improve its function and the contractility of the myocardium. I think this is basically how it works. It has been used intravenously, and I believe it has been used also subcutaneously with some hopes. So in this case, we are now moving into a real study to assess whether treatment with omecamtiv or omecamtiv mecarbil, we'll learn with time, in patients with heart failure who had a reduced ejection fraction, whether this would lower the risk of heart failure events and cardiovascular death. Well, we have here more than 8,000 patients, inpatients and outpatients, with symptomatic chronic heart failure in an ejection fraction of 35% or less, to receive this mecarbil drug at dosages of 25 milligrams or 37.5 milligrams or 50 milligrams twice daily, or placebo. When we talk about primary outcome, composite of first heart failure event, hospitalization or urgent visit for heart failure, or death from cardiovascular causes. During a median follow-up of actually 2 years, the primary outcome event occur in 37% of the omecamtiv mecarbil group versus 39.1% in the placebo group. So 37%, 39%. And then there are, this is actually the aspect of the combination of the death and hospitalization. And then when they look at patients who died, is 19.6% in one group, 19.4% in the other group. So basically what you really are working here is on the hospitalization or no hospitalization, urgent visit for heart failure, no change in mortality. And then the Kansas City cardiomyopathy questionnaire, I think it did not work much. So in conclusion, and again, I read the conclusion, among patients with heart failure and reduced ejection fraction, those who receive omecamtiv mecarbil had a lower incidence of composite of a heart failure event or death from cardiovascular causes than those who receive placebo. Well, let me ask perhaps Athena, what do you think about this one?
Well, I'm excited about a new mechanistic approach. I'm a little underwhelmed by the findings because, this is a sick population. Their baseline medication use, this was pre-SGLT2 inhibitors, and there's 20% Entresto use. So the question is there really incremental value? And then the last point is, they didn't have improvement in symptoms either, despite this reduced hospitalization. So how do we convince patients it's the real benefit here? I'm a little underwhelmed, but perhaps it would be a small place you could use it before you move to a VAD, or the patients you can't keep out of the hospital. So I see a very narrow potential use.
Yeah, this is patients with very low ejection fraction, maybe they did better. Gilles?
Yes, there is a big competition out there for heart failure. And what we have seen with other drugs is clearly more impressive than what we see here for, rehospitalization for heart failure. Absolutely no signal on death and no signal on symptoms. I cannot see this drug as a first-line treatment pretty soon. I cannot imagine that.
Okay, Christine?
Yeah, I mean, I think one of the things that is notable is it's the first inotrope that didn't end up increasing mortality. So that's good. But I agree, without the benefit on symptoms and just, looking at heart failure hospitalizations is tough, given all the new agents that have come out in the recent, and how do you fit it all in? And like Dr. Fuster mentioned, it did seem like the people with the lowest EF may have done the best with the drugs. So like Athena said, maybe it is going to be in a selected population.
Okay, thank you very much, Vinod.
Yeah, I mean, I agree. I mean, since we're spending so much energy and time on cases Q and symptomology, I think that's really where we have to drive how our patients are doing, not just that they had a 10% decrease in the N-terminal pro B type. I think that's less impressive to me than our symptoms. And so really, I think we have to drive our therapy towards patient symptoms at the end of the day.
Okay, thank you very much. Now we get into an impressive one. Pericarditis comes from time to time into our scenario, and this is another time. Here we have the RHAPSODY trial run by Dr. Alan Klein from the Cleveland Clinic. It's a phase 3 trial of interleukin-1 trap or neutralization by rilonacept in patients with recurrent pericarditis. Well, we all have faced these patients. Apparently here they say is an statistics that approximately 15 to 30% of patients who have an initial pericarditis episode will have recurrence despite of the treatment with colchicine and otherwise. Interesting, we all know interleukin-1 is a very important pro-inflammatory molecule in any pathway of inflammation, and it is pointed out that probably is important in patients with pericarditis. Having said that, let's go into the detail of the study. This is a phase 3, as I mentioned, multi-center, double-blind, international randomized trial of this drug, rilonacept, in patients with acute symptoms of recurrent pericarditis, as assessed on a patient-reported scale. And these patients all had systemic inflammation, so they all had an elevated C-reactive protein. This was important for the entry into the study. The patients presented with pericarditis recurrence were receiving standard therapy, and they were enrolled in a 12-week running period during which rilonacept was initiated and background medications were discontinued. Patients who had a clinical response were randomly assigned then to 1:1 ratio to receive continued rilonacept monotherapy or placebo, administered subcutaneously once a week. So here is the drug given alone with the failure of the others, something different than with the lipid study that we just mentioned. The primary efficacy endpoint was the time to the first pericarditis recurrence, and safety was also assessed. Well, the number of patients actually is not a significant number, 86 patients with pericarditis pain and elevated CRP. And during the run-in period, near resolution of pain was 5 days in these patients and CRP in 7 days. So they, in general, they responded very rapidly. A total of 61 patients underwent the real randomization. And the recurrence is amazing to me. 7% in the rilonacept group had recurrence and 74% in the placebo group. Usually you don't see these kind of figures, you know. Now, the most common adverse event with rilonacept were injection site reactions in upper respiratory tract infections. Let me read the conclusion that is pointed out also in this paper of the New England Journal. Among patients with recurrent pericarditis, rilonacept led to a rapid resolution of recurrent pericarditis episodes and to a significantly lower risk of pericarditis recurrence than placebo. Well, you know, Christine, what do you think? I hope you are impressed here.
Well, I am impressed. You know, having taken care of a few of these patients myself, it's a tough thing, and you don't want to give them steroids for sure, because then it just gets into a worse situation. So this is great to have something that's effective and works quickly like this.
Yeah, Gilles?
Yes, you know, IL-1 is a new kid on the blocks of cardiomarkers for coronary disease, for pericarditis, for myocarditis, and we have a number of these drugs that can play on this marker. And I think here we have something very impressive on top of colchicine already acting on this marker. So I don't know what can we get better than this, because clearly these patients are very difficult to treat, and here we have something very effective.
Yeah. Vinod, you still do pericardiectomies for recurrence? It's actually rare, I think, no?
Yeah, you know, in the last couple of months, I've done a couple of these, and these are patients, you know, it's possible that this will, you know, eliminate that. And that's perfectly fine. They're not very easy procedures. They become very tedious. So I think the more therapy we have for this, the better off you are. It's a full sternotomy. It can be a tedious operation. It's very big to the patients. I think we would probably surgically just deal with those that are very restrictive and have created a rind, a calcified rind is where I think you'd end up on the surgical end. Okay, thank you. Athena?
Yeah, impressive results. I think the mechanistic finding is important because it confirms IL-1's an important player. And I guess the only caveat is I think 15% of the patients were post-pericardotomy syndrome, and one of the side effects was an increase in LDL and triglycerides. So I'd be a little concerned about those cardiac patients, and we'd have to watch their cholesterol a little more closely, but impressive results for sure.
So summarizing the pharmacological 4 papers, we have ivanicumab for refractory hypercholesterolemia, and rilonacept for the recurrent pericarditis. I hope we learn with time to name this properly. But I think these are two very interesting observations actually on patients that we actually see. Okay, well, you have done so well that the expectations are high on the next few papers. Now we are getting into coronary artery disease. Very interesting, the first paper is the so-called, I think it's HARP-MINOCA. This is a paper presented by Dr. Harmony Reynolds from NYU here in New York, and is entitled Coronary Optical Coherence Tomography and Cardiac Magnetic Resonance Imaging to Determine Undergoing Causes of MINOCA in Women. Well, very interesting syndrome. This means myocardial infarction with non-obstructive coronary artery disease. And I am told that this accounts for 6 to 15% of patients with spontaneous myocardial infarction, particularly in women. And the problem is the 4-year rate of major cardiac events is significant, approximately 25%. There's an important entity in which we don't have a real understanding of what actually happens. Well, I think the paper today that is presented here, it gives us a sense of what is going on because of the technology being used. So coronary optical coherence tomography to get inside the coronary arteries and magnetic resonance imaging to look at the myocardium, assessing ischemia or no ischemia. So it's a prospective multi-center international observational study with women who had clinical diagnosis of myocardial infarction, and they reveal less than 50% stenosis in the major arteries. The OCT was performed in the multi-vessel approach, and this was followed by CMR, or magnetic resonance imaging. And it was very well done. The evaluation was blinded. There was a core laboratory for CMR. And the number of women enrolled were 16 sites, were actually about 300. And 170 were actually with clear diagnosis of MINOCA. And they have all done. And then the question is, what were the findings? Well, a definite or possible culprit lesion was identified by OCT in 46% of these participants in the study. What they found is plaque rupture, intraplaque cavity, or layer plaque. And actually, in about 53%, 74% had an abnormal MR. And from these, over 2/3, it was ischemic. So it fits with the findings by the OCT. And therefore, they conclude that an ischemic etiology was identified in 64% of women with MINOCA, and a non-ischemic was identified in 20%. And basically, the conclusions are that multimodality imaging with coronary OCT and CMR identify potential mechanisms in 84% of women with diagnosis of MINOCA, 3/4 of which were ischemic and 1/4 of which were non-ischemic, myocarditis, etc. So again, Athena, what do you think? This is very interesting, isn't it?
Oh, I think it's fantastic. And it really adds incremental information to the literature, because this was a group that we had discounted for a long time. And we know that their MACE can be quite high at 5 years, 25% MACE, and mortality 11%. So it's significant. And I think using some of the newer modalities, such as OCT in particular, so that we can treat these women appropriately for secondary prevention. I think one of the challenges will be the cost analysis. Do we need to do all three? And I think that's where we're going to find some of the challenges.
Good point. Gilles? Gilles? You are in mute.
Yes, yes. Yeah. So, sorry about that. Yes, I think it's very interesting to see that we can get a diagnosis where a few years back we were unable to say anything about these ladies. coming to the hospital with myocardial infarction and, let's say, normal coronaries. I'm a little surprised by the fact that we have only one patient in this group with spontaneous dissection. I think in my practice, it's more often than this. And when you look at all the causes, it's many of these patients, you find a cause related to atherosclerosis, plaque rupture, plaque erosion with a thrombus, intraplaque cavity. So a large group of these patients actually had atherosclerotic plaque complications.
Okay, thank you very much. Vinod?
Not much really to add to this, not much to add to this component of it. I think that we are increasingly using imaging to kind of make diagnosis for this, especially in the coronary OCT department. And I think I'm looking forward to how we're able to better predict how patients are going to do. So not more than what Athena and Gilles have already said.
Christine? You are in mute, Christine.
Sorry about that. Yeah, no, I agree with everything that's been said. And also, I think it would be interesting to see, like you said, whether we could just do an MRI. Do we have to do the invasive tests? You know, what would be the protocol for how we would include these tests and what to evaluate?
I don't know, but yeah, I think, frankly, we learn about pathogenesis with all these technologies. I'm not entirely sure how applicable are going to be. It would be nice, but I don't know economically. But anyway, thanks very much. Interesting paper, very good paper.
Valentin, I have a question to follow up. It's a small number of patients, but it seems that it's a much more frequent event. So I don't know if they had trouble recruiting into the trial or that the enrollment was a challenge, but I think we see it a lot more than this 170, 145. So just a question.
I suspect when you see these patients, you get distracted and you do all sorts of things, coronary spastic phenomena, and you start giving, you know, and I think that's what happened. They get diluted into the system, I would say. We have a paper now, which is interesting. Is a paper from the group in Seoul, Korea, a very good group, Dr. Myung Ki Hong, and is entitled 1 month dual antiplatelet therapy followed by aspirin monotherapy after drug-eluting stent implantation, randomized 1 month dual antiplatelet therapy trial. I think it's interesting because this is the way, at least I read the literature, Gilles, and you are very much into all this. I thought the dual antiplatelet therapy was almost mandatory in patients undergoing stenting, except more recently in the patients with significant complex disease, maybe using ticagrelor alone after dual therapy for a month or so, you can move forward. But what I didn't know is that you could use aspirin alone and moving forward. And this is what this paper is saying. And I don't want to go into too much detail, but basically, these are stable patients. So we are not talking about patients who have very complex disease. And I think this is one of the aspects. And second, I think that all the trials in the past that talk about dual antiplatelet therapy, the stents were more thrombogenic. The interventionalists were not as experienced. So rather than going into numbers, this is basically what the paper is saying. And I'd like to know your opinion, Gilles.
Yes, you know, this idea of having a very short period of the APT starting the day of the PCI and ending possibly 1 month later, it's something we have known with bare metal stents. But since we had drug-eluting stents, and you may remember that we had lots of stent thrombosis initially with these drug-eluting stents, this duration was expanded to 1 year or at least 6 months. And with the new generations of these stents, it's a different story. We must see this last generation of drug-eluting stents, just like bare metal stents. We can go with 1 month of the APT after stenting, and that's good enough. We have had lots of data before this study coming from registries or from randomized studies, but randomization was for the type of stent, BMS versus DES, for example, but always with 1 month of DAPT because these patients were at high bleeding risk. What is new here is that we deal with all comers, stable patients, and we treat them with 1 month versus 6 or 12 months of DAPT, and it works. The stent thrombosis rates are very low in both groups. It's not an issue anymore. And you start seeing these patients differently. You don't have to prolong the APT for 6 months or 12 months when they are stable.
So it's interesting. Athena, how do you react to this?
Well, it's a constant challenge, I think, because patients need to come off sometimes, or we delay other surgeries or procedures. So knowing what type of stent they had as a non-interventionist would be important, to know that they had the right kind of stent and the right size artery and it was appropriately expanded. It would be very important to know that this is generalizable so that we can safely stop it in a month.
Thank you, Christian.
No, I don't have much to add. I mean, obviously, being able to stop it sooner is great. And like you say, it's nice to have an interventionist give you some advice about what to do.
The only thing that worries me is that this concept of monotherapy during these 12 months is fine, but these patients later on, they have a natural history that is bothersome. And I wonder if we don't get fixed into monotherapy forever. Maybe it's wrong. I don't know. I don't know what is your opinion about this.
So, Valentin, a quick question for Gilles, maybe specifically on this, is that I think that sometimes we make one idea for all the stents and for all the patients. So if they're diabetic patients, or if there are patients in renal failure, or if there are patients with a lot of stents, I'm not sure that just sending generic a message of 1 month therapy makes a lot of sense to me. I think we have to really break these patients down into subgroups, insulin dependent versus non and others. And I know they've done some subgroup analysis, but I think a generic statement actually hurts the population of all the patients we're treating. I think we have to be more specific.
Basically, what you are saying is we have to how intense is the agents that we have and how intense is the disease that we have.
Right.
And this balance is where you make the judgment here.
Right. I don't think we can generically say 1 month DAPT. I think that's a risky proposition if we just generalize that to the public.
Except though the movement is in complex disease, you can use this, prasugrel or ticagrelor, I suspect, monotherapy. And in simple disease or stable, you may use aspirin. But anyway, you're right.
Absolutely.
I'd like to go into the next paper. And actually, the next paper, I think, Gilles, you participated. This is the ALPHEUS paper. It is ticagrelor versus clopidogrel in elective percutaneous coronary intervention, a randomized open-label phase 3 trial. I'd like to understand this study, Gilles. I read it actually several times, and it seems to me, and tell me if I am wrong, that now that the stents are less thrombogenic and all of that, you still think that some degree of damage, which is very little maybe with some enzyme elevation and so forth, one could test ticagrelor versus clopidogrel, which is what is done here, and see if perhaps ticagrelor, less enzyme elevation, less injury, means better long-term follow-up. Was this the basis of the study? I'm just asking because you are one of the participants here.
Yes, thank you, Dr. Fuster. Yes, this study was performed by our group, the action group, and in 49 centers. And yes, we have seen in the other studies, the event rates now after PCI are so low that it becomes impossible to test a new drug to prevent stent thrombosis, for example, when your stent thrombosis rate is 0.2%. So what's left in PCI is this big question about myocardial injury and myocardial infarction after PCI. And when you look at these definitions coming from the European Society of Cardiology, especially, you have up to 30% of patients, 30% of patients with a significant rise of troponin. And the next question, of course, is, does it matter? And we have lots of data out there published in very good journals saying, yes, it does matter because it has an impact on heart events, including mortality. And knowing this, the next question, of course, is what can we do to prevent these myocardial injuries? And of course, one hypothesis is that it is platelet related because you may have emboli, you may have dissection and thrombus, you may have all sorts of complications related to platelet activation during the procedure. And of course, the standard of care for these days is aspirin and clopidogrel. Why not test a more potent drug like ticagrelor in association with aspirin? So this is what we did in these 2,000 patients.
Pre-procedure.
Yes, we started at the time of PCI, and there was absolutely no impact whatsoever on any endpoint. And just to say that it may be another reason causing this myocardial injury, like a mechanical squeezing of a side branch, for example, and it's not thrombus related, or maybe even ticagrelor is not potent enough, and we need something stronger, like a GPI or cangrelor, to prevent a little bit this myocardial injury.
Okay, thank you very much. Any other comment, Christine or Athena or Vinod?
No.
It's a negative study, but certainly the hypothesis, I understand it. Okay, well, thank you very much. Actually, in the same line, now we have another paper. This is about the brain. And is the paper from the THALES study. Ticagrelor added to aspirin in acute non-severe ischemic stroke or transient ischemic attack of atherosclerotic origin. Basically, we are talking about a syndrome in the lines that you were discussing, Gilles. A little bit of a TIA, a little bit of a stroke, but really not very significant. And the question is not cardioembolic. So what do you do? And most of the time we have used aspirin. Some people have used aspirin and dipyridamole based on previous studies. But here the test is the use of ticagrelor plus aspirin versus aspirin alone. And this is the study. There was an original study, THALES, that I don't have to go into the details. Let me focus into this one. The patients were randomized. The patients did not have a non-cardio. The patients with a non-cardioembolic, non-severe ischemic stroke or high-risk transient ischemic attack, they were randomized to ticagrelor, 180 milligrams loading dose on day 1, followed by 90 milligrams twice daily for the first month, or placebo, in which contain aspirin. So one is aspirin plus ticagrelor, the other is aspirin with placebo. And the aspirin was given 300 milligrams on day 1 and then 75 daily until day 30th. Within 24 hours of the symptoms onset is where the randomization was done. Analysis in patients with and without ipsilateral potentially causal atherosclerotic stenosis. Let me tell you, the original THALES was the same study, but they didn't look if the clot was coming from the left side or the right side, the right carotid or the left, or was ipsilateral or not. This second study of THALES, they look at, and actually it gives a difference. What basically they do, they look at, is the event is ipsilateral, and the drugs obviously see which one works, or there is no actually ipsilateral relationship. And then you have two different strategies. And these were the results, actually. If the event was ipsilateral, certainly the combination of drugs worked better than aspirin alone, 8.1 events versus 0.9. And this has these are the events means a recurrence of a stroke or death within 30 days. Okay, so it was better if everything is ipsilateral, you give both drugs. On the other hand, when there was no real ipsilateral association, either intracranial or extracranial, there was no significant difference in giving aspirin versus aspirin and ticagrelor. And then the incidence of bleeding was significantly very, very low, so I don't have to go into the detail. So basically what the study is showing that when we have a minor stroke that is not cardioembolic or a TIA, if the situation is ipsilateral, if you can identify by imaging or otherwise, then the combination of two drugs is meaningful versus one alone. Okay, Christine, how would you react to this?
Well, I think it makes some sense pathophysiologically, and obviously that's why they did a pre-specified analysis. It is a subgroup of a major trial. So, you know, I don't know. It would be nice if it was a pre-specified trial. Make me feel a little better about bringing this out into practice broadly.
Okay. Athena?
Yeah, the subgroup analysis is always a concern. And if it was in a larger group, would we see more bleeding risk in an elderly population? Because I do worry about that.
Although the risk was relatively small, no? I don't remember, 0.5.
Correct.
Yeah, 0.5 to 0.1. Yeah, okay. In the general group, in the group that was ipsilateral, actually the bleeding rate was the same. Was in the other group. Okay. Yes, Gilles, what do you think?
I think it's interesting because this is the second subgroup analysis that we have for this question. The first one was in the Socrates study. Now it's in the THALES study, and they both go in the same direction. I would be a little cautious because this analysis, when you look at the P4 interaction, was not significant. So we have globally a positive study, but for this subgroup specifically, even if the trend is real, numerically speaking, there was no significant interaction in this analysis. So again, it's more hypothesis generating, but it is a second independent study of this type going in the same direction.
Thank you. Vinod, are you excited?
Yeah, I'm not sure I'm excited about this, but I do think that I like the way they actually framed the last four words of the conclusions in an exploratory analysis. I'd love to see a randomized trial in this and really put this to bed. As Gilles said, this has been discussed before. If it shows up in a randomized trial, Valentin, then I'll be excited.
Understand. All right. Yeah, you surgeons get excited by other things than this one.
We do not get excited by strokes. I want you to know that.
Yeah. Okay, sure. Now let's move into heart failure. And there are two studies. I will mention the first one and then a comment about the second. Is the so-called the SOLOIST study. This is from Deepak Bhatt, is the one who presented it, and is entitled Sotagliflozin in patients with diabetes and recent worsening of heart failure. The name of the study is the SOLOIST-WHF trial. Well, you know, basically, you know, these different drugs, dapakizumab and some others, they all appear to be very important in patients with heart failure, either with diabetes or not. And now there is almost a paper published every week about it. And this is an interesting one in patients with actually with this new drug, but of the same family of the SGLT2 inhibitors. And basically what they do is that patients have heart failure, but they deteriorate. They can have diabetes or not. And then these patients enter into a randomization scheme. The patients did not have renal failure. This is what is important about this particular group. The patients presented with signs and symptoms of heart failure. They needed intravenous diuretics. BNP, pro-BNP was elevated, and they could have diabetes or not. And basically, what they found is that sotagliflozin was better than placebo, and that is the number of events per 100 patients at 18 months of follow-up were actually 98 in the placebo group and 70 in the treated group. You say, but how many events? They talk about events that are very minor and not necessarily are big events. Otherwise, these patients, it would be impossible to be alive with all of this. But that's what they find. And then what they find is the same thing when they look at mortality alone. These first figures I gave to you, 98 versus 70, is the combination of total cardiovascular death, heart failure hospitalization, urgent heart failure visit, maybe to an emergency room, and so forth. But the similar data is when they look separately. For example, death and heart failure together, 86 events versus 60, or when they use, anyway, basically this drug is not different, as far as I can tell, to the other ones that we know. They have a good study done with the Kansas City heart failure cardiomyopathy scoring, certainly is significantly better by the use of this medication. And renal function continues to be intact in the group treated with this drug versus deterioration with the group treated with placebo. So it's another type, and I'd like to see what is your opinion, Gilles, about this particular mode of therapy. Not different than the others, Frank.
No, except that this drug provides SGLT2 inhibition, but also SGLT1 inhibition on the gastrointestinal tract, especially, and it may explain also some of the side effects that we see with this drug that we didn't see with the others. But altogether, when we look at the efficacy, it's quite impressive. We have large reductions of the primary endpoint, and we have favorable trends on mortality. So it's very attractive. I'm a little bit concerned about the side effects and the tolerance of the drug globally.
Thank you very much. Christine? Any comments?
I feel the same way. It looks very impressive, and again, adds just to more data for these drugs in heart failure. There are some more side effects, so that also raises my concern.
Athena, can I ask you, what is your prediction? This is a tremendous competition among 3 companies. Do you think this is going to make the drug more affordable?
That would be
of the 3.
Yeah. Well, if I ran the zoo, I would make it more affordable, but it should, absolutely. So we would hope so, because that would help the patients. I think my concern about this drug, and maybe why they stopped it early, they withdrew funding for it. And so that's why they added this other sort of usual endpoint of urgent hospitalization. So there's that caveat. They're definitely underpowered for any more major effects. So is there a class effect? Seems to be. The other thing I think we learned from this is you could start it early. That's, I guess, the tack they take. There wasn't, I think, now that we know so much about the other agents, a lot of concern about starting it early. So I guess there's some reassurance on that end. And then the last point is, if we have a drug that doesn't work on, SGLT1 with the GI side effects, maybe I wouldn't choose that one for my patients.
Okay, thank you. Any other comment? The SCORE trial is very similar, except the patients have glomerular filtration rate of less than 60, but the results are very similar, frankly, and at least, and certainly renal function does not deteriorate. It stays almost the same with some deterioration in the placebo group. So basically we have here a new type of SGLT2 inhibitor, which, as you mentioned, it is affecting both receptors, the 1 and the 2, perhaps comparing. I thought though, dapagliflozin also affected the 1. Yeah, maybe I am wrong. Well, anyway.
But you know, Valentin,
Yeah.
the prices usually don't come down until there is a third competitor, right? When there are two competitors, almost nothing happens. So when a third comes on the market that's equivalent, then maybe to your original question, maybe that will start to occur a little bit.
Interesting. Well, thank you. Well, finally, I was thinking on Christine, and says we have to bring something from atrial fibrillation, and I was looking, and finally I found 3 papers that are worth mentioning. Let me go to the first one, which I think is interesting. Rivaroxaban in patients with atrial fibrillation in bioprosthetic mitral valves, the RIVER trial. This is a study I think was in Brazil. And basically the question is, bioprosthetic valves with atrial fibrillation, obviously we have been using warfarin. The question is what about these new NOACs, rivaroxaban? And basically we are talking here about 1,000 patients with where had mitral valve, a bioprosthetic valve, and then they look at the usual primary outcomes, particularly stroke and mortality, and where others like hospitalization for heart failure and so forth. And they look at both, and interestingly, it came out that rivaroxaban appears to be a trend to be superior to warfarin for whatever reason. For example, death from cardiovascular causes or thromboembolic events, the incidence was 3.4% versus warfarin 5.1%. The incidence of a stroke was 0.6% rivaroxaban, 2.4% with warfarin. And then we have a measure bleeding, interestingly, 1.4% for rivaroxaban versus 2.6% for warfarin. So before I ask Christine, Vinod, what do you think? You changed these valves. Well, you now to repair them.
Yeah, I mean, we obviously try to repair them, and that's part of the problem that, you know, mitral valve surgery is so, the outcomes are so dependent on the type of mitral valve that you're dealing with, the type of ventricle you're dealing with, that always becomes difficult. Right now, if this holds true, this would change the standard of care, which is currently warfarin. And anecdotally, we use warfarin, and that's part of the ACC-HA guidelines. And so this has a potential for changing that. I am worried a little bit about the reason for their mitral valve replacement. And also, and that for me makes a big difference if they're functional patients, primary patients, that we're dealing with multiple factors at this point, not just the anticoagulation component of it.
Thank you. Maybe let's go to the 2 other papers, unless any of you have any comment. Yes, Athena, you have a comment about it.
Yeah.
I do. I had a similar concern with Vinod. It was in, this was a younger group, predominantly women, and in Brazil. So I wonder if they were mostly rheumatics since they were replaced at a younger age. And so rheumatics, as you know, may have a different risk factor. So, and they also had a lower CHADS-VASc. So if we looked at an older group of patients that are getting bioprosthetics valves, would the bleeding risk go up? So that's my concern. I'd like to know what they were replaced for.
Good point. Thank you. Other comments? Okay, we have here a couple of papers. I think they go side by side. One may follow the other. The first one is entitled Enhanced Monitoring for Atrial Fibrillation Following Cardiac Surgery by Dr. Subodh Verma from the University of Toronto. The title is the SURGE-AF CardioLink trial. Well, we all know that following cardiac surgery, there is an incidence of atrial fibrillation which has been equated to about 30 to 50%. And there is also evidence that this atrial fibrillation may have recurrences. Now, this first study, basically, they look at one of these monitorings with a band a constant monitoring following surgery for the first few weeks. And they look at whether or not atrial fibrillation occurs compared with another group in which if it appears clinically is fine. If not, you don't know. And basically the conclusion is that the number of cases in which atrial fibrillation is seen by this device over a period of 1 month is actually in 20%, while in the group that were not monitored was actually 2%. So I think the message of this paper, at least is very common atrial fibrillation following cardiac surgery. This was valve replacement or CABG. But the fact of the matter is what this means. So Christine, what is your first reaction to the paper?
Well, I'm not surprised, really. I think that, if you monitor people, especially high-risk people and people who just had surgery, you're going to find AF. And, what they found was that when you really look for prolonged AF, which was, greater than 24 hours, then you're talking more like 3%. And at this point, it's hard to know what to do with the very short duration AF. So you'd need a randomized trial of anticoagulation to show that it did anything. And then when you look at the absolute outcomes are so low, I don't know that we're going to be able to do that kind of a trial. But it's interesting, and it makes you know that it's out there if you monitor for it.
Well, this leads to the next study in the final, excuse me, maybe we will discuss both at the same time.
Sure.
The second study from the Scripps research, from the Scripps Clinic, is the 3-year clinical outcomes in a nationwide pragmatic clinical trial of atrial fibrillation screening, is the MSTOPS study. And let me define, it was about a few thousand patients, from 3,000 to 5,000, depending on the groups that were divided. And there they did a screening over a 3-year period, which is interesting. And here they have outcomes. What they don't have is who took anticoagulants, who not, so they don't answer your question. And basically the results were that in those patients who actually had atrial fibrillation, the number of events was higher. But again, I don't have any idea were anticoagulated or not, that those who did not have atrial fibrillation on the monitoring. On the other hand, if they look at the patient's monitoring versus no monitoring, the number of events were the same. So basically what they are doing is you're identifying a group, I think, that has atrial fibrillation, and here is the group that is actually potential for thromboembolism, but we don't have any idea about anticoagulation. So how do you react to the study, Christine?
Well, I think that it's important to point out that the control group was not a randomized control group. So they randomized to 2 sets of monitoring, delayed and early monitoring, and then they combined them together. And they sent out this request for this monitoring to 100,000 people or something, and they got these 2,000 people who wanted to wear a monitor. So you're comparing these 2,000 people who said, okay, yes, I'll get a monitor, to the rest of the whole cohort that's matched on certain features. So it's hard to know whether that's because the people that chose to be monitored were healthier and they did better, or if there was something that their doctors did with regards to that monitoring that helped them do better. But I don't think that this is just hypothesis generating. It doesn't really answer that question.
It's not published yet, so it's difficult to know also the details. There's a lot of detail on anticoagulation. So now I'm going to make a survey. Just listening to the 4 of you, I heard that you liked the paper on the hypercholesterolemia resistance. You liked the paper on the pericarditis. You liked the paper on MINOCA. You liked the paper with the heart failure, the score, the soloist, and so forth. And then on the atrial fibrillation papers, you liked plus minus the bioprosthetic valve atrial fibrillation. So give us a summary, Athena. Which one really is the winner?
Well, that would be tough, but I think it's the pericarditis paper. The findings were dramatic. It's really a clinical need that we have. So the close tie would be MINOCA, but if I have to choose one, it's got to be the pericarditis.
Christine? Christine, I don't hear you. Sorry.
Apologize. I would agree about that choice. And I think for me, the runner-up would be the hypercholesterolemia paper.
Excuse me, is this a second or the first is pericarditis or
The
hypercholesterolemia?
first one is pericarditis.
Okay,
Second
good.
would be the hypercholesterolemia.
Okay, Vinod?
I always end up going with the smartest person, Athena. So I'm going to say also the pericarditis one, partly because I'm trying not to see those patients on the operating room table. That's why I'm trying to prevent you from sending me those. And then I actually like the hypercholesterolemia one. I think that's going to have some futures going down the road. Thank you. Gilles?
I agree, but I have to say something different. So I would say that the RIVER study with rivaroxaban being used in valvular AFib now is something new. I mean, these drugs were used only in non-valvular AFib. Now we're moving to a different target.
Well, look, we have reviewed 13 papers in a period of 63 minutes. And I think this is great. This actually speaks for who has been here today. You have been fantastic. You know why? Because you have expressed your opinions very shortly, very succinctly, all making a lot of sense. And this is wonderful to be chairing a meeting like this with people like you. I really appreciate your presence here today. A wonderful experience for over 1 hour. The best experience today, because if I go back when I got into this hospital at 5 in the morning today, up until now, this by far is my best experience.
I agree.
Well, you too.
Valentin, those are surgeon's hours, man. That's a surgeon.
Yeah, you have to be in the operating room. Next time we'll put your Zoom down there.
That's right. That'll be fun. That will be fun.
Okay, well, thank you very much to all of you, and I really appreciate it. Thank you.
Thank you.
Bye-bye.